Every second, billions of your cells are busy copying their DNA, a process essential for life. But cancer cells take this to another level. They replicate their DNA even faster and with less accuracy than normal cells. This rapid, sloppy copying is what helps tumors grow and spread so aggressively. Imagine a factory running at double speed but with no quality control. That's what's happening inside cancer cells. Understanding this difference is the key to targeting cancer with specific drugs. So what if we could disrupt this DNA-building machinery right when cancer cells need it most? That's where antimetabolites come in. Antimetabolites are a fascinating class of drugs. They're designed to look almost identical to the natural molecules your cells use to make DNA and RNA, things like folate, purines, and pyrimidines. Cancer cells, which are dividing rapidly, grab these imposters, mistaking them for the real thing. Once inside, these fake molecules either block the enzymes that build nucleic acids or get incorporated directly into DNA and RNA, causing catastrophic errors. This clever trick is why antimetabolites are so effective, especially during the S phase of the cell cycle, when DNA synthesis is at its peak. Make things clearer, antimetabolites are divided into three main families: folate antagonists, purine analogs, and pyrimidine analogs. Each group targets a different part of the DNA building process, but all share the same goal: disrupting the cancer cell's ability to replicate its genetic material. By understanding these families, you'll see how each drug works and why it's chosen for specific cancers. Let's start by exploring folate antagonists, the oldest and one of the most important groups in cancer therapy. Folate is an essential vitamin that your cells need to make thymidine and purines, two of the fundamental building blocks of DNA. Without folate, cells simply can't make new DNA. This makes folate metabolism a prime target for cancer therapy. By blocking folate's action, we can effectively halt the production of DNA in rapidly dividing cells, especially cancer cells. This is the foundation for the use of folate antagonists in chemotherapy. Methotrexate is one of the oldest and most widely used chemotherapy drugs. It works by binding to an enzyme called dihydrofolate reductase, or DHFR, with much higher affinity than folate itself. DHFR normally recycles folate into its active form tetrahydrofolate. When methotrexate blocks this enzyme, cells can't make thymidine and DNA synthesis grinds to a halt. Methotrexate is a cornerstone in treating acute lymphoblastic leukemia, osteosarcoma, and non-Hodgkin lymphoma. At lower doses, it's also used for autoimmune diseases like rheumatoid arthritis and psoriasis. Let's look closer at how methotrexate does its job. By blocking DHFR, methotrexate prevents cells from recycling folate into its active form. Without active folate, cells can't make thymidine, a key DNA building block. This stops DNA synthesis in its tracks, especially in fast-dividing cells like cancer. The result? Cancer cells can't multiply and the tumor's growth slows or stops. This precise targeting is why methotrexate remains a mainstay in cancer therapy decades after its introduction. Methotrexate isn't just for cancer. At lower doses, it's also used to treat autoimmune diseases like rheumatoid arthritis and psoriasis. In cancer, it's most commonly used for acute lymphoblastic leukemia, osteosarcoma, and non-Hodgkin lymphoma. The dose and schedule depend on the disease being treated, and careful monitoring is essential to avoid side effects. Methotrexate's versatility and effectiveness make it a vital tool in both oncology and rheumatology. Here's a clever twist: in high-dose methotrexate regimens, patients receive Leucovorin rescue afterward. Leucovorin has already reduced folate, so it bypasses the blocked DHFR step entirely. This protects normal cells while tumor cells, which took up more methotrexate, still take the hit. This strategy allows for higher, more effective doses of methotrexate while minimizing damage to healthy tissue. Timing is everything. Leucovorin must be given at just the right moment to work its magic. Methotrexate is powerful, but it comes with risks. Key toxicities include myelosuppression, mucositis, hepatotoxicity, and nephrotoxicity, especially with high-dose regimens. That's why aggressive hydration, urinary alkalinization, and careful Leucovorin timing are critical. Before each Leucovorin dose, doctors always check methotrexate levels and kidney function to ensure safety. Managing these risks is a vital part of methotrexate therapy. Pemetrexed is a newer folate antagonist that takes things a step further. It inhibits not just DHFR, but also thymidylate synthase and GRFD, multiple enzymes in the folate pathway. This multi-target approach makes Pemetrexed especially effective in certain cancers. It's a backbone drug in mesothelioma and non-squamous non-small cell lung cancer. To reduce toxicity, it's usually paired with folic acid and vitamin B12 supplementation. Next, let's talk about purine analogs. These drugs masquerade as adenine or guanine, two of the 4 bases in DNA. The most well-known are 6-mercaptopurine and 6-thioguanine. Once inside the cell, they get incorporated into DNA and RNA as fraudulent nucleotides. This disrupts purine synthesis and causes strand breaks, stopping cancer cells from growing. Mercaptopurine is especially important in the maintenance phase of pediatric acute lymphoblastic leukemia. Critical point with purine analogs: they're metabolized by an enzyme called TPMT, or thiopurine methyltransferase. Some patients have low TPMT activity, which puts them at risk for severe, even life-threatening myelosuppression at standard doses. That's why TPMT or NUDT15 genotyping is now standard practice before starting therapy. This personalized approach helps doctors tailor treatment and avoid dangerous side effects. Fludarabine and Cladribine are purine nucleoside analogs, heavily used in chronic lymphocytic leukemia and hairy cell leukemia. They work by inhibiting DNA polymerase and ribonucleotide reductase, enzymes essential for DNA synthesis. These drugs are notably immunosuppressive, so patients are at higher risk for opportunistic infections. That's why doctors often prescribe PJP and antiviral prophylaxis during treatment. Now let's move to the pyrimidine analogs, arguably the most widely used antimetabolites in solid tumor oncology. These drugs mimic pyrimidine bases, another essential component of DNA. By interfering with pyrimidine metabolism, they block DNA synthesis and stop cancer cells from dividing. This group includes some of the most important chemotherapy agents in use today. Fludarabine or 5-FU is a classic pyrimidine analog. Inside the cell it's converted to F-TUMP, which inhibits thymidylate synthase, the enzyme that makes thymidine. Without thymidine, DNA replication can't happen. 5-FU is a backbone of regimens for colorectal, gastric, breast, and head and neck cancers. Its effectiveness and versatility have made it a staple in oncology for decades. Capecitabine is an oral prodrug of 5-FU. It's converted to 5-FU preferentially in tumor tissue, making it more convenient for patients. Capecitabine is famous for causing hand-foot syndrome, a side effect where the skin on the hands and feet becomes red and sore. It's important to always screen for DPD deficiency before starting capecitabine, as this can lead to severe, sometimes fatal, toxicity. Cytarabine, also known as RSE, is another key pyrimidine analog. It gets incorporated directly into DNA, terminating chain elongation and stopping cell division. Cytarabine is a cornerstone of acute myeloid leukemia induction therapy. High-dose cytarabine carries a unique risk, cerebellar toxicity, so doctors perform neurochecks before each dose to monitor for side effects. Gemcitabine is a deoxycytidine analog that works similarly to cytarabine, but is used across a broader range of cancers, including pancreatic, bladder, and lung cancers. It's valued for its relatively favorable toxicity profile, making it a popular choice in many treatment regimens. Gemcitabine's ability to disrupt DNA synthesis makes it a powerful tool in the fight against cancer. Let's recap. Folate antagonists like Methotrexate and Pemetrexed target DHFR and thymidylate synthase, with mucositis and nephrotoxicity as signature risks. Purine analogs like 6-mercaptopurine, Fludarabine, and Cladribine disrupt DNA and RNA synthesis, with myelosuppression and TPMT risk as key concerns. Pyrimidine analogs like 5-FU, Cytarabine, and Gemcitabine block thymidylate synthase or get built directly into DNA, with hand-foot syndrome and cerebellar toxicity as signature risks. Every drug in the antimetabolite class exploits the same vulnerability, a cancer cell's desperate need to copy DNA fast. By targeting this weakness, these drugs can slow or stop tumor growth. However, because normal cells like bone marrow, GI lining, and skin also divide quickly, they can be collateral damage, leading to side effects. Balancing effectiveness and toxicity is the art of chemotherapy. Side effects of antimetabolites often mirror the tissues in our body that divide the fastest: bone marrow, the lining of the gastrointestinal tract, and the skin. These tissues are hit hardest because they're constantly renewing themselves, just like cancer cells. That's why patients may experience low blood counts, mouth sores, or skin changes during treatment. Understanding this helps us manage and anticipate side effects. Because of these risks, monitoring is a crucial part of antimetabolite therapy. Doctors regularly check blood counts, kidney and liver function, and watch for signs of infection or organ toxicity. Supportive care like hydration, folic acid, and vitamin B12 supplementation can help reduce side effects and keep patients safe during treatment. Modern cancer therapy is increasingly personalized. Genetic testing like TPMT or DPD screening helps doctors choose the safest and most effective doses for each patient. This approach minimizes the risk of severe toxicity and maximizes the chance of successful treatment. Personalized medicine is transforming how we use antimetabolites and other chemotherapy drugs. Antimetabolites are often used in combination with other chemotherapy agents. This multidrug approach attacks cancer from different angles, increasing the chances of success. Each drug in the combination has a unique mechanism and toxicity profile, so careful planning is essential to maximize benefit and minimize harm. Methotrexate is a key drug in the treatment of acute lymphoblastic leukemia, especially in children. It's used in both the initial and maintenance phases of therapy. The goal is to eradicate cancer cells while preserving as much normal tissue as possible. Methotrexate's effectiveness in leukemia has saved countless lives. In osteosarcoma, a type of bone cancer, high-dose methotrexate is a standard part of treatment. It's often combined with other drugs to increase effectiveness. Because of the high doses, Leucovorin rescue and close monitoring are essential to prevent toxicity. This approach has improved outcomes for patients with this aggressive cancer. Methotrexate is also used in non-Hodgkin lymphoma, another cancer of the immune system. It's part of multi-drug regimens designed to target different aspects of cancer cell growth. The flexibility of methotrexate makes it a valuable component in many lymphoma treatment protocols. At lower doses, methotrexate is widely used to treat autoimmune diseases like rheumatoid arthritis and psoriasis. It helps control inflammation and prevent joint damage. The dosing and monitoring are different from cancer treatment, but the underlying principle, blocking cell division, remains the same. Leucovorin rescue is all about timing. Given too early, it can protect cancer cells; too late, and it won't help normal cells. That's why doctors carefully monitor methotrexate levels and kidney function, adjusting Leucovorin dosing as needed. This precision ensures the best possible outcome for patients. Pemetrexed is a backbone drug in non-squamous non-small cell lung cancer. It's often combined with other agents to improve outcomes. Folic acid and vitamin B12 supplementation are standard to reduce toxicity. Pemetrexed multi-target approach makes it especially effective in these cancers. In mesothelioma, a rare cancer often linked to asbestos exposure, Pemetrexed is a key part of treatment. It's usually given with cisplatin, another chemotherapy drug. This combination has become the standard of care, improving survival and quality of life for patients with this challenging disease. 6-mercaptopurine is a workhorse in the maintenance phase of pediatric acute lymphoblastic leukemia. It helps keep the disease in remission by disrupting DNA and RNA synthesis in any remaining cancer cells. Careful dosing and monitoring are essential to avoid toxicity, especially in patients with TPMT deficiency. 6-thioguanine works similarly to 6-mercaptopurine, getting incorporated into DNA and RNA and causing strand breaks. It's used in certain leukemias and requires the same careful monitoring for toxicity. Both drugs highlight the importance of personalized dosing based on genetic testing. For starting purine analog therapy, patients are tested for TPMT and sometimes NUDT15 activity. These enzymes determine how quickly the drugs are metabolized. Low activity means higher risk of toxicity, so doses are adjusted accordingly. This approach helps prevent severe side effects and ensures safer treatment. Fludarabine is a mainstay in chronic lymphocytic leukemia (CLL) treatment. It's effective at inducing remission but is also highly immunosuppressive. Patients need close monitoring for infections and may require prophylactic antibiotics and antivirals during therapy. Cladribine is especially effective in hairy cell leukemia, a rare type of blood cancer. Like fludarabine, it inhibits DNA polymerase and ribonucleotide reductase. Its immunosuppressive effects mean infection prevention is a key part of care. 5-fluorouracil is a backbone drug in colorectal cancer treatment. It's often combined with other agents to increase effectiveness. Its ability to block thymidylate synthase makes it especially potent against rapidly dividing tumor cells. Beyond colorectal cancer, 5-FU is also used in gastric, breast, and head and neck cancers. Its versatility and effectiveness make it a go-to drug in many solid tumor regimens. Monitoring for side effects, especially hand-foot syndrome, is important during therapy. Capecitabine offers the convenience of oral dosing, but it comes with unique risks. Hand-foot syndrome is more common, and DPD deficiency screening is essential before starting therapy. This ensures patients can safely metabolize the drug and avoid severe toxicity. Cytarabine is the backbone of induction therapy for acute myeloid leukemia, AML. Its ability to incorporate into DNA and terminate chain elongation makes it highly effective. High-dose regimens require careful neuro checks to monitor for cerebellar toxicity. Gemcitabine is widely used in pancreatic, bladder, and lung cancers. Its favorable toxicity profile and effectiveness make it a popular choice. Gemcitabine disrupts DNA synthesis, slowing tumor growth and improving patient outcomes. Managing the side effects of antimetabolites is a team effort. Doctors, nurses, and pharmacists work together to monitor for toxicity, adjust doses, and provide supportive care. Patient education is also key. Knowing what to watch for helps catch problems early. Research continues to improve antimetabolite therapy. New drugs, better genetic testing, and improved supportive care are making treatment safer and more effective. The goal is always to maximize cancer control while minimizing harm to normal tissues. Antimetabolites and folate antagonists remain some of the oldest and most essential drug classes in oncology. By targeting the DNA-building machinery, they exploit a fundamental vulnerability in cancer cells. Understanding how these drugs work, their risks, and how to manage side effects is key to successful treatment. That wraps up our look at antimetabolites and folate antagonists. In the next episode, we'll dive into alkylating agents and explore how they attack DNA in a completely different way. Stay tuned for more insights into the world of cancer therapy and how science is helping us fight back.